So we all know that the most common histopathological subtype of ovarian tumors is, of course, high-grade serous tumors, and mucinous ovarian carcinomas, they form only about 3% of all the epithelial tumors. However, they present at an earlier age, and at that point in time, the survival is better than high-grade ovarian cancers. However, when they present at a later stage, the survival is much lesser than the high-grade serous ovarian cancers. It's not moving again. Yeah, so mucinous ovarian tumors, they develop on a continuum from benign epithelium to pre-invasive borderline tumors on to mucinous carcinomas. KRAS is an early event, and as the tumor progresses on to carcinomas, you have your oncogenic alterations of, and they express HER2/neu and T53 mutations. It's important to distinguish a primary mucinous ovarian tumor from a GI malignancy. So it is important to do endoscopies, upper GI endoscopy, as well as a colonoscopy before you actually go on to doing surgery for a primary ovarian mucinous tumor. We also need to remember that even though they are CK7 highly positive, they might still express CK20 and a CDX2. Histological classification is important for mucinous tumors. They have progressed from the classification put forward in 2003 to 2014 because our surgical extent is now determined by this histological classification. And what used to be mucinous intestinal grade 1 to 3 is now divided into expansile and an infiltrative type of tumor. Grading is not recommended, and the seromucinous type is now divided into endometrioid, serous, low-grade mucinous, and so on and so forth. So how do we address an apparently early-stage mucinous carcinoma? For the young, unilateral salpingoophorectomy with unilateral salpingoophorectomy with peritoneal staging procedures can be done. We can do fertility-sparing surgeries, and we can do it through the MIS route. Risk of recurrence is much lower in the mucinous tumors than for the high-grade serous tumors, being 6 versus 20%. For the older age group, of course, we would prefer to do a bilateral salpingoophorectomy. Appendectomy. One would think that since it is a mucinous tumor, so the appendiceal involvement would be very high. However, all these studies show us that the appendiceal involvement is only as low as 1.1% only. So there is no indication of restaging if appendectomy has not been done previously. Also, if the appendix appears to be abnormal macroscopically, we definitely need to do appendicectomy. If macroscopically normal, you do not need to remove it. Some gynecologic oncologists, they are still advocating for routine appendicectomy as part of surgery for MOC, since morbidity is not increased by doing this. The advantage is that it is challenging at times to distinguish a primary MOC from metastatic mucinous carcinoma, and removal of the appendix might help with differential diagnosis and improved staging. Peritoneal involvement too is as low as appendiceal involvement, being only about 1.1%. However, if the peritoneum is positive or the omentum is positive, it mandates a restaging if previously not done due to poor prognosis in advanced stages. So while performing staging, a thorough exploration of the abdominal cavity, peritoneal washings, and cytology, omentectomy, peritoneal biopsy, etc. is mandatory. Lymphadenectomy is another issue in mucinous carcinomas. Now, in non-mucinous histologies, nodal involvement is as high as 20 to 30%. However, in mucinous tumors, nodal involvement is as low as 2.6%. Matsau et al. Assessed the impact of lymphadenectomy, and they showed that adequate lymphadenectomy enhanced survival in all subtypes except the mucinous carcinomas. However, there are these two studies which have been put forward, and where they show that in the infiltrative type of subtype of mucinous carcinomas, the lymph node involvement can be as high as 27%. So therefore, we conclude that lymphadenectomy can be omitted in the expansile subtype. However, it should definitely be performed for the infiltrative subtype. Now, the catch point is that during frozen section, we cannot tell which subtype it is. So either we perform lymphadenectomy for all tumors, or we counsel the patient regarding need for additional procedure if it turns out to be infiltrative. Fertility sparing surgery is advocated in the mucinous ovarian tumors because these tumors mostly occur in the younger age group. However, Guy et al. Found out that the histological subtype did not influence the oncological outcome when it comes to fertility sparing surgery, and Rodriguez et al. Reported a worse survival with more lapses with the infiltrative subtype. Uterine preservation in the infiltrative subtype again is a debatable point, and it was found that there's definitely an increased recurrence if we preserve the uterus in the infiltrative subtype. So to summarize, for stage 1A, 1B expansile type subtype, fertility sparing surgery can be done. We need not do a lymphadenectomy. However, if it is infiltrative subtype, we need to do both a para-aortic as well as a pelvic lymphadenectomy. When it comes to HIPEC, now because of this paper published by Van Driel et al., where they showed an improvement both in the OS and the PFS when we do HIPEC, so now we want to do HIPEC for all our patients. But what drug to use? So understanding the behavioral and biological similarities between your MOCs, your colorectal cancer, and your pseudomyxoma peritoni, HIPEC seems to be a reasonable option in treating metastatic mucinous tumors. However, controversy remains as to what chemotherapeutic agent should be used for HIPEC in these sort of cases. So this is just reiterating the NCCN guidelines, which say that for mucinous tumors, primary invasive mucinous tumors of the ovary, they are uncommon. The upper and the lower GI tract should be carefully evaluated, and if mucinous histology is confirmed by intraoperative frozen section analysis and there are no suspicious lymph nodes, consider omitting lymphadenectomy totally. Comparing the NCCN guidelines with the European guidelines, the NCCN guidelines, they have directed as to what we should do as per the stage of the tumor, whereas the European guidelines have told us how we should do the surgery as per the histological subtype. Coming to clear cell carcinoma, they form about 2 to 10% of all primary epithelial tumors. They are characteristically hormone negative, that is ERPR negative and WT1 negative as well. However, diagnostic markers are NAPSIN A positive and HNF1B positive. Endometriosis is associated with up to 35 to 50% of them. They present at a younger age group. Earlier stage presentation, bilaterality is uncommon. They are resistant to chemotherapy, what we have heard during the morning. Better survival than mucinous cancers, but worse than high-grade cancers. Now, all these three studies, the JGOG 3016, JGOG 3017, and GOG 172, they have shown that no matter how the chemotherapy is exhibited, whether given dose dense or upfront, that is Taxol carboplatin, or even intraperitoneal chemotherapy, the clear cell carcinomas, they're relatively chemoresistant no matter how you give them the chemotherapy. So surgery becomes the mainstay of treatment in all clear cell carcinomas. We need to work up all clear cell carcinomas for Lynch syndrome because there is a strong association between them and the endometrioid carcinomas. Comprehensive surgical staging is an absolute mainstay of the treatment. It mandates resurgery and surgical staging if this has not been previously done. Fertility sparing surgery and observation/monitoring can be done for stage 1A tumors. The recurrence rate of stage 1C patients with clear cell carcinoma was 22.5% if fertility sparing surgery was done for them. We need to remember this. Same surgical procedure is to be done as we do for high-grade serous ovarian carcinomas. Now, there is no significant prognostic difference between patients with residual tumor diameter of less than 1 centimeter or more than 1 centimeter. However, for patients with no residual tumor, there is a significantly better progression-free survival than for those where there is some amount of tumor is left behind, regardless of the size of the tumor left behind. Now, what is the role of lymphadenectomy? Now, in this METO9 Italian multicentric trial, it was found that 7.1% of patients underwent fertility sparing surgery. 240 had ovarian cancer patients were studied. Lymphadenectomy was performed in 47.9% of the patients. And of these, 54.3 were in stage 1 and 2, and 39.2 were in advanced stages. Lymphadenectomy was associated with a longer DFS in both the early and the advanced stage disease, and also higher OS. Lymphadenectomy was an independent prognostic factor along with early stage at diagnosis and also at a multivariate analysis. So frontline chemotherapy with or without taxanes did not have any significant impact on survival. So what does this tell us? This shows that lymphadenectomy, even at advanced stages, improves survival in case of clear cell carcinomas. Now, clear cell carcinomas, they are often associated with endometriosis, and the presence of endometriosis has been associated with a good prognosis. However, surgery in such cases becomes a challenge, as so many of us have seen that there is a lot of fibrosis, and you might, in endometriosis, you might want to leave behind plaques of the disease or even deposits of the disease on the rectum or the sigmoid or something, but this definitely should not be done when there is a clear cell carcinoma associated. Clear cell carcinoma patients, they also which are stage greater than 1C2 and 1C3, they show a marked risk of mortality even after complete surgical resection. And this, they said, is possible because possibly there is existence of occult metastasis in patients with ovarian clear cell carcinoma, because they're associated with endometriosis, and you might have endometriotic deposits here and there where you have not seen, or very small microscopic endometriotic deposits. So even though you think that you have done a fantastic surgery, it might actually be suboptimal.
Can you close it quickly?
Yes, this is my last slide, which I'm not going to talk about because I think this NCCN guidelines have already been shown, and thank you so much.